I'm going to be talking about screening guidelines first, and then I'm going to move on to new technologies. We have low-risk patients, we have high-risk patients. I'm going to discuss those separately and the screening indications for both groups. I'm going to talk about indications for breast MRI. Breast MRI is a great test, not for everybody. And I'm going to go over the difference between a screening workup and a diagnostic workup, because a lot of patients don't understand what the difference is. Okay, we all know all these. The two greatest risk factors for breast cancer are simply being female and getting older. Nothing you can do about that. Nothing you can do about a lot of these things, but just being aware of these risk factors is helpful in managing your patients. Having a first-degree relative with breast cancer, I think Dr. Schwartzberg talked a lot about this. I'm not going to go into it a lot. A lot of these risk factors have to do with prolonged exposure to estrogen. Early menarche and late menopause both expose the breast tissue to estrogen for just a longer period of time. And then there are the biopsy results like atypical ductal hyperplasia, lobular carcinoma in situ that will increase your risk factors, and then of course BRCA1 and BRCA2. I have this slide screaming at you because Dr. Schwartzberg's actually had this information in his talk, but I have it in a different kind of percentage format. It's kind of a scary statistic that 70% of women who develop breast cancer have no family history or other risk factors other than being female and getting older. So I hear women all day long. I work here at the Methodist Breast Center, and I hear women all day long say, well, I don't have any risk factors for breast cancer because it doesn't run in my family. And just please reinforce with your patients that's a small risk factor, that everyone needs to be screened for breast cancer. All right, so low-risk patients. These are the predominant amount of patients that you have in your practice. These are the recommendations for these patients. Starting self-breast exam, having a clinical breast exam starting at age 20, and what we recommend, the American College of Radiology recommends having a baseline mammogram at age 35, and then starting yearly mammography at age 40. Not every other year, not at 50, I'm not even going there. Those recommendations were relatively flawed. And I'll get real angry if I talk about it for too long. So starting annual screening at 40. These low-risk patients are the patients that have less than 15% lifetime risk of breast cancer. High-risk patients, totally different screening recommendations. They have similar self-breast exam and clinical breast exam recommendations, but the big difference in these patients are that they need to start yearly mammography at age 30, or if they are high risk from a first-degree relative that developed breast cancer, they need to start 10 years before the age of diagnosis of that relative. So if their mother developed breast cancer at age 38, then they need to start yearly mammography at age 28. These patients also, it's recommended that they also have yearly breast MRI. And what we'll do a lot of times in high-risk patients is alternate the breast MRI every 6 months, 6 months off with the mammogram. So they would have their mammogram and usually a breast ultrasound, say in January, and then July have their breast MRI. Following January, they'll have their mammogram. The following July, they'll have their breast MRI. High risk is defined as a lifetime risk greater than 20%. And if you notice the difference, there's an in-between there. What about the 15 to 20%? Well, they're intermediate risk. And those screening recommendations are relatively controversial. A lot of those patients will still do yearly breast MRI. But what I encourage you to do is talk to your patients and evaluate their risk factors. There are online risk assessment tools, such as the Gale model and the Klaus model, and there's lots and lots and lots of models to evaluate breast cancer risk. But I encourage you in those intermediate risk patients to evaluate them to see if MRI should be included. We're also available, and please call and ask. We're very, very willing to help. Shifting gears. Indications for breast MRI. Like I said, breast MRI is a fantastic test, but it is an extremely sensitive exam and not for everybody. With that high sensitivity, you sacrifice a lot of specificity. So if we did the test on everyone, the false positives would be, through the roof. So what we generally do most of breast MRI patients, new diagnosis of breast cancer is one of our biggest population bases. The BRCA1 or 2 gene mutations or first-degree relatives with BRCA1 or 2 gene mutations, and any patient with a lifetime risk of breast cancer greater than 20%, those high-risk patients. We do a large number of patients with St. Jude. We here in this practice do a large number of patients with St. Jude that had mantle radiation for Hodgkin's lymphoma. And then the genetic syndromes that Dr. Schwartzberg mentioned, Cowden's, Lee-Fraumeni, and I always have a hard time pronouncing this one, Banyan-Ryle-Rubalcaba syndrome. All right. Screening versus diagnostic mammogram. A screening and a diagnostic mammogram initially are identical exams. A screening mammogram includes the top to bottom craniocaudal view, the side view, one of each of those views of each breast, four views, four mammogram pictures. A diagnostic mammogram starts out exactly the same way. It's those four views. The difference between the two, screening mammograms can be done anywhere we have accredited mammo facilities. They can be done off-site. They've been done. There's lots of doctors' offices that do them. You know, we don't have to be there with the patients to have that done. Diagnostic mammography needs the radiologist there to interpret, to make recommendations, to perform ultrasound if needed. Diagnostic mammography we do for patients that they're either recalled from a screening mammogram. So if the patient has their screening mammogram, there's an abnormality, we call them back, get them back, do extra images, sometimes an ultrasound. And for patients who have symptoms, new masses, nipple discharge, pain, skin changes, there's a long list of abnormalities that we do diagnostic workups for. Another common imaging modality for evaluating for breast cancer and other breast symptoms is breast ultrasound. We do lots and lots of breast ultrasound. It's a fantastic complement to the mammogram. I tell patients all the time that the two imaging techniques, they each have their weaknesses, they each have their voids. The two of them fill in a lot of the gaps for each other. Ultrasound is the gold standard for evaluating for cysts versus solid masses. It can characterize your solid mass. Does it look benign? Is it smooth and oval in shape? Or is it suspicious? Is it very irregular and have shadowing? It helps delineate whether we need to do a biopsy or not. We use it sort of as a screening tool in high-risk patients that have really dense breast tissue, because one of the things it does is it sees through all that dense breast tissue and evaluates for the presence of masses. And we use it to guide breast biopsies. All right, I'm going to talk about digital mammography. I'm going to talk about CAD, which stands for computer-aided detection. I'm going to talk about 3D mammography, which is the latest, greatest invention so far for us. And I'm going to talk a little bit more about breast MRI. 95% of the mammography units in the United States are now digital. Most everybody has moved to digital equipment. They were proven several years ago to be better for women, young women and women with dense breasts, which is a lot of women. And so we're fortunate to have been all digital for a long time. CAD is computer-aided detection. It analyzes each mammogram image for masses and calcifications. It is not reading the mammogram. It is not that smart. It doesn't know that this image of the right breast in the craniocaudal projection is the same image of the right breast in the oblique projection. It doesn't merge that information. It doesn't read the mammogram. It simply is a computer algorithm that puts little marks on things. And I tell our residents, it's like a little brother poking you going, well, look at that. Look at that. You got to look at that. You know, and it just makes you take a second look. It's called second look technology. It really does help. It makes you look again, makes you evaluate things. I use it a lot for calcifications. But 3D mammo is the best. It's also called digital tomosynthesis. Instead of just looking at a single picture of the breast, the unit actually moves in an arc over the breast, and it obtains 15 images. With those 15 images, it reconstructs all that digital information into 1 millimeter slices. So if we have a breast that compresses to 5 centimeters thickness, I have 50 images to look at in each of those projections. It's amazing. What we've struggled with in the past is overlapping tissue. That breaks that down completely. Things that look like densities, spiculations, I can see through that. I know that that's not real. On the flip side of that, in the very dense breasts, we can see masses that are hiding in that dense breast tissue, because you take away all the surrounding density and the mass or the architectural distortion, it's just all of a sudden visible. So with that, we'll decrease our false positives, see cancers that we can't see otherwise. The statistics that we found, and this is held true for our practice too, the lesions that you can only see on 3D mammo, that you can't see on traditional mammo, that you can't see on ultrasound, 50% of those will end up being cancer. So it's really remarkable technology. Breast MRI is near and dear to my heart. I absolutely love breast MRI, even though it's not for everybody. It's one of my favorite imaging tests that we do. We use a specialized breast coil that the patient's actually lying prone in the breast coil, and the breasts are down in the coil, and they're imaged We do multiple volume acquisitions. And we give the patient, we do several images before contrast, and then we give the patient IV contrast. And we usually do, it's about 4 sequences after the contrast, and what we're doing is evaluating the pattern of enhancement of the breast tissue, because benign tissue has a very characteristic way of enhancing. Suspicious cancerous tissue has a totally different way of enhancing. We always use the current mammogram with it to correlate to make sure that we're, if the patient has, clips or a mass or anything seen, with the current mammogram and ultrasound, we'll be able to correlate that and make sure we're seeing the right thing. Unfortunately, we've had several patients say they would rather have the MRI than have a mammogram because they really don't like mammograms. Well, unfortunately, it doesn't replace the mammogram, because just like I was talking about mammography and breast ultrasound, each test has gaps that the other fills in. And breast MRI cannot yet see microcalcifications, and we need to be able to see microcalcifications to evaluate for DCIS. Our indications, I went over this earlier. This is a little bit more of a breakdown of the indications. New diagnosis of breast cancer. Unfortunately, we can't do MRIs on every single new diagnosis of breast cancer, because unfortunately there are a lot of new diagnoses of breast cancer, but we really try in invasive lobular carcinoma and DCIS that shows up without microcalcifications associated with it. Those are our 2 times that we really push to have an MRI on those patients pre-op. Invasive lobular is an insidious carcinoma. It can present without much of any imaging findings. So when we do find it, invasive lobular a lot of times is going to be bilateral, it's going to be multifocal, and so we want to know that before we send the patient to surgery. The second indication for evaluation of high-risk patients, like I said before, the BRCA-positive patients, Hodgkin survivors, and patients with strong family history, those are our 2 greatest populations of patients that we do. Less commonly used indications are using it as a problem solver. MRI can really be a star in a patient with that presents with an axillary lymph node that's positive for metastatic breast cancer with a negative mammogram and ultrasound. We can nearly all the time find the mass on MRI because MRI is so sensitive, it'll show us the mass. In patients with equivocal palpable findings, they have something that feels like breast cancer, and I have nothing on my mammogram or ultrasound to correlate with that. Those patients I'll send for MRI. Postoperative evaluation in patients with positive margins after lumpectomy, and for evaluating for recurrence. Post-lumpectomy patients can have very difficult mammograms and ultrasounds to read, and if we have a suspicious finding, a scar doesn't enhance at all, but a cancer will. And then we have patients that the best way that we can see their cancers with MRI, we will monitor their result to neoadjuvant chemotherapy. I just put on here down at the bottom, we also evaluate breast implants with MRI, but we're not looking for cancer. We're not giving contrast. It's an MRI, but it's a totally different test. All right, here's the case. This patient, we looked for that second cancer. We looked really hard for that second cancer. We did ultrasound surveys of both breasts. We had 2 views of each mammogram. We didn't see it. So when she came back after the MRI, she came back in, and what correlated, we measured the size of the lesion on the MRI, we measured the distance from the nipple, and we scanned again, and we saw this little shadow, and that was her second cancer. It was so subtle, invisible on the mammogram and very subtle on the ultrasound. But had we not done that, we would have missed her second cancer, and if she had only had a lumpectomy, then she would have still had cancer. This doesn't happen all that infrequently. We do find a lot of occult disease with a breast MRI. All right, and that's what I've got. Mammography saves lives.